Thank you. Good morning. Good morning. We're going to get started. If everybody could take a seat, please. Good morning, everyone. If everyone could take a seat, we really appreciate it. We're going to get started. We want to welcome everyone to our in-person MHOA conference. Is right. We're really excited that you could all be here. We're really excited. This is one of our biggest conferences to date. So here at the Cape, so we're really excited. We appreciate you all coming and taking the drive here, especially in the rain this morning. We just wanted to give you a couple of housekeeping items. I first want to introduce myself. My name is Ray Dick. I'm a health director in the town of Westford, and I'm president here at MHOA. We wanted to just remind everyone for your CEUs, what you would need to do is you want to make sure that your tag is scanned so that you're able to get your CEUs for every class or session that you attend. Please just make sure that your tag is scanned in so that you get your credit for today. All evaluations for your CEUs will be online. You will be sent an evaluation link. Speaker presentations and all handouts will be on our MHOA website. We want to thank all of our staff and all of the conference committee for putting together this conference this year. They work really hard. Come January, we start planning all over again. So I really just wanted to give a round of applause to all the staff and our conference committee. This morning's keynote speaker is going to be virtual. His name is Dr. Paul Biddinger, and he is the Chief Preparatory Continuing Officer of the Mass Brigham in Boston. He holds the Anne Pristino MPH Endowed Chair in Emergency Preparedness. He is also the Director of the Center for Disaster Medicine in Massachusetts General Hospital. Additionally, he serves as the Director of the Emergency Preparedness Research, Evaluation, Practice Program at Harvard T.H. Chan School of Public Health. He holds appointments at Harvard Medical School and the Chan School. He serves as the medical officer for the Mass One Disaster Medical Assistance Team and the National Disaster Medical System in the U.S. Department of Health and Human Services. He's an active researcher in the field of emergency preparedness. He's lectured nationally and internationally on preparedness and disaster medicine topics. He has authored numerous articles and books, chapters on topics such as disaster medicine, emergency medical operation, and has responded to numerous prior disaster events, including Hurricane Katrina, Superstorm Sandy, the Boston Marathon bombings, the Nepal earthquakes, and many others. He completed his undergraduate study in international relations at Princeton University and attended medical school at Vanderbilt University. He completed his residency training in emergency medicine at Harvard University. And we really would love to welcome Dr. Paul Biddinger. Thank you.
Thank you so much. It's really a pleasure to join you. I'm terribly, terribly sorry that I can't join you in person. After holding out for 2.5 years, I tested positive for COVID over the weekend, and you don't want me in the room with you all for this conference. This group understands that better than absolutely anybody. But I'm really, really sorry. This is a great event. I've been fortunate to join this meeting previously, but I'm really, really thrilled to be able to join you now. It looks like I can see from the back of the room. I think my slides are up, so hopefully we'll dive in. And what I wanted to speak about, not surprisingly, is emergency preparedness. And you all understand again better than anybody that the landscape around public health emergency preparedness is really changing in so many different ways. The threats are changing, the political, the social environment, the needs are changing, and of course we've learned so much in the last couple of years of responding to the ongoing pandemic. So I wanted to sort of offer a few thoughts about what is changing and maybe what we can all do together to adjust and adapt to the threats that we see. And then at the end, I would love to answer questions if there are any from the audience, and hopefully we'll leave a little time at the end to do that. So the three things we are going to talk about, or I'm going to talk about, are about the changing preparedness threats that we're facing. Talk about those operational challenges. Again, you're all aware of them. You see them every day in your communities and in your jobs. And talk about some of the things that people are doing to try and adapt to these trends. So, it's just worth saying out loud, and I think all of us have to be messengers of this, that the threats really are increasing. I think there's often a lot of skepticism out there about whether there are more disaster events or whether this is just, we see it on the media because it makes good ratings, because it's sort of sensationalistic. But the reality is that there are more disaster threats, and the impact of those disaster threats is actually increasing. Some of this has to do, of course, with the increasing population, that sort of by definition, if there are more people, the disasters affect more people. But it's also the way we live, that we are continuing, even in Massachusetts, but certainly across the country and the world, to be more clustered in urban areas. So disaster events that affect these clustered areas of the population affect more people. We continue to be more coastal, and in general, a lot of the threats tend to be around the coasts, and therefore putting the population near the threats increases population impact, and others that I'll speak about. But it's a pretty clear trend line when you look at this, that the disaster events are increasing. I would also draw your attention to the fact that we'll talk a fair amount about climate change in the next couple of slides, but that flooding, extreme weather, drought, extreme temperature, those things are all climate-related hazards. And it is undeniable that what we're seeing has a strong link to climate change, and it really has a lot of important implications for how we look at our planning. So again, just to sort of state the obvious, that we've never been at this level of atmospheric carbon dioxide, and the science talks about very clearly the ways in which that's affecting both our health, but specifically the climate that we live in. I do believe, separate from even just the emergency preparedness perspective or lens that I always have, that this is just the biggest public health threat that we face. Hopefully you all follow the Lancet's countdown, which is a really, really good source of data for the impact of climate change on human health, and tracking both what progress we are not making as a planet to try and mitigate climate change, but also really describe the problems that we're facing. And I think, just unfortunately this morning, you may have seen in the New York Times, there's a reasonably depressing article that talks about how we're falling short globally of our climate change pledges and goals, and what that may mean for future human health. I would also note that the U.S. Department of Health and Human Services has a good climate change, climate resilience toolkit, as well as a literature portal. And so if you're not familiar with that, it's a great source of information if you're looking for data on the impact of climate change on health, on public health. And it has tools for both healthcare systems and for public health about ways you can try and mitigate against the impacts of climate change. Most of you are pretty familiar with graphics like this or others that describe the overall complex impact of climate change on health. It's not just the severe weather and atmospheric issues that I'll say more about in another couple of slides, but it's driving so many other relatively less obvious impacts. So how we use our land, the food supply that we have available, how it's driving changes in agriculture and livestock use. Climate change, like all disaster threats, is unfair and disproportionately affects those who are already vulnerable. It is not having even effects across racial and ethnic lines. Poorer communities are definitely harder hit by many of these impacts. And ultimately, this is making us sicker as a population. We have increasing rates of cardiopulmonary illness, and when we have severe weather threats, particularly heat stress and poor air quality days, we have increased presentations of patients with acute medical conditions to the emergency care system. It has other obvious mental health consequences as well, just because of what all this means. So if we draw down just a little specifically into what some of these impacts are that we will tangibly see, that we are tangibly seeing, One of the easy ones, one of the obvious ones is changing hurricane activity. The Atlantic Ocean is warming, and of course, warm water is the engine, it's the power source for hurricanes. And what it means is that the hurricanes we're seeing are stronger on average as we see them. A couple weeks ago, I was down in Florida responding to the consequences of Hurricane Ian, and it was an incredibly devastating hurricane. There's hurricanes always, of course, cause a lot of destruction, but it was a severe storm, as you all know, when it came ashore, and the fact that the storms we see will be more severe is of great concern. One thing, hopefully you're all aware of, and this really does affect the whole state, not just the Cape or not just the eastern coastal portions of Massachusetts, but is that we in Massachusetts are more likely to get less warning for the major hurricanes that come our way, just because of the way the currents work. If a hurricane is going to come up and hit New England, ironically, we get less time to prepare than often the Gulf Coast does, because it starts to go north very, very quickly. Hurricanes can easily come inland and have devastating consequences for hundreds of miles. And so even in Worcester and Springfield and the Berkshires, you can get significant impact from a storm as it washes across the state. Many of you remember the impact of Hurricane Irene in Vermont, which obviously is not a coastal state, but caused enormous amounts of flooding. And I think we have similar kinds of threats across the entire state. If it's not just the hurricane, heavy precipitation is a threat that I think is underappreciated. One of the other impacts of climate change is that when we see heavy rainfall, it actually is greater in amount and often longer in duration. And so Hurricane Harvey is thought of as a hurricane. You can remember the terrible flooding we saw in Houston years ago. In Hurricane Harvey, really the problem was not so much the hurricane. It wasn't the sea level, the storm surge, or the wind speeds, but it was that it was a rainstorm that just didn't move. And it just sat there and rained and rained and rained in incredibly large volumes for days. And that's really the cause of the flooding. What we're seeing is that these severe precipitation events are causing flooding events in places we have not seen them geographically before. So, for those of you that are in parts of the state that have not seen major flooding, it's going to be imperative to look at your current flooding risk from major rainfall events, because, and I'll say more about that also coming up in a second, but we are seeing more flooding in places that have never flooded before because of heavy precipitation. An example here is the Louisiana floods in 2016 near Baton Rouge, and this, people are used to seeing pictures of flooding from Louisiana, especially around the southern part of the state, often from hurricanes. But this part of the state, sort of outside of Baton Rouge, flooded in places that had never ever had flooding like this before, and it was again just a series of rainstorms that just didn't move. We in Massachusetts remember Snowmageddon so very well, and though it is not clear on total whether we will have more or possibly less snowfall than we've had in history, probably less. When we have severe storm events, it is increasingly likely that we will have large snowfall events. And by the way, go back quickly. This point is an extraordinarily important one, and often our emergency management colleagues appreciate this really, really well, but a lot of others in government, in policy, and the public don't. When we talk about looking at our disaster planning, people love to look at history and say, what's happened in the last 5 years, 10 years, 50 years, 100 years. And I think climate change is a really, really important example of the fact that we can't look backwards. We have to look forwards in our emergency planning. The way the climate is going to change in the coming 10, 30, 50 years really affects our municipal infrastructure differently. And we can't base our climate plans or climate assumptions on what we've seen in previous decades. So to that end, I'll just give a couple of examples. Many of you may have seen that there was a study that came out of the Harvard School of Public Health looking at sea level rise and looking what it means for infrastructure. They looked at 78 different metropolitan statistical areas along the Gulf Coast and Atlantic coast, And 25 of those 78, so nearly a third of those areas have at least half their hospitals at risk of flooding, just from a Category 2 hurricane, let alone something more significant. The Boston area, metropolitan Boston area, was actually number 3 in the country behind New York and Miami. So it is of increasing concern how much healthcare infrastructure we can lose from relatively more minor events. We've done a fair amount of climate change modeling in my own healthcare system, and our results are somewhat similar to what this study found. I don't think people appreciate the fact that in relatively minor hurricanes or significant precipitation events, hospitals could actually be flooded and lost. The same could be true of nursing homes, of skilled nursing facilities. And a lot of the data that we base our planning assumptions on for hospitals, for again, which nursing homes are likely to flood, is substantially out of date. And FEMA flood maps usually don't tell the full picture of what we're at risk for now, and certainly not what we're at risk for in the next 10 to 30 years. I think heat is also underappreciated. Clearly we're not in the southern part of the United States, but one of the statistics I like to share that I think is really informative, though depressing, is that in Massachusetts in general, we have about a week of temperatures greater than 90 in a summer, somewhere between 7 to 10 days where the temperature is greater than 90. In the next 10 to 20 years, that is anticipated to be 30 days. So nearly a full month of the summer intermittently will be greater than 90 days. And by 2070, so in the next 50 years, the entire summer is going to be greater than 90 degrees, essentially without relief. And that has enormous implications for our built infrastructure as well as for our communities. We talked a lot this summer. We had a significant set of heat waves, as you all remember. And we know that our elderly, our poor, those that live in houses that are uncooled, really struggle during those heat waves. We put together cooling centers. You all took a lot of action, of course, during these heat waves. But instead of it being 3 days, 5 days during 1 month, and then maybe another set of days during another month, if it really is the entire summer, I think that has extraordinarily important implications for what the health of our communities is going to need. I will also tell you that many buildings, including healthcare buildings in New England, do not have their cooling on emergency power. And so if there's a brownout or a blackout, the health consequences of how many healthcare facilities would potentially need to evacuate because they don't have electrical generators that can power their cooling is substantial. Some of you might remember back from Hurricane Irma that a substantial number of nursing home residents died when that nursing home lost power, couldn't power their cooling, and did not evacuate. So the frequency, the intensity, the severity of heat waves is going up, and very much for us here in Massachusetts. Zoonotic outbreaks, so outbreaks of disease that come from animal populations are absolutely increasing. There are lots of factors that are driving it, not just climate change, but it's the increasing contact between human and animal populations as we both spread. It's the frequency of travel. Things can move around very, very quickly. It's some of the changes in farming and livestock techniques that we have. But we have seen we've seen that 70% of the emerging diseases we have seen in the last several decades are zoonoses. And the frequency of presentation of zoonoses is increasing. Hopefully all of you are following the current Ebola outbreak in Uganda and know that we have a lot of Ugandan expatriates that reside or travel through Massachusetts. That outbreak is definitely concerning right now. You know that the federal government currently is limiting return air travel from Uganda to its 4 key screening airports, but then people can absolutely end up in Massachusetts, rule out if they have the right epidemiologic risk factors, not only just symptoms, but they've been around someone who was diagnosed with Ebola. But it's a challenge, and I think it will be a continuing challenge for all of us. And then, I know we don't often necessarily think of active shooter events as public health events, but tragically, we absolutely are seeing increases in the numbers of active shooter events. We are seeing increases in terrorist or community violence incidents as well. And you know that the mental health consequences of these events for communities are absolutely extraordinary. You can see what the community of Uvalde is still struggling with right now. So many communities across the United States. And I think from, again, the physical and mental well-being of communities, these kinds of incidents absolutely have a big impact and affect public health. Hospitals and governmental structures, town municipal governments, including municipal public health, have been targets of cyber threats. And particularly the healthcare public health threats have been increasing since COVID. For whatever reason, and there are several of them, but the increase in cyber attacks seems to have concentrated on health and public health, and the number of attacks has gone up again from a third of organizations in 2020 to 2/3 in 2021. And I think most all healthcare organizations are actively being attacked on a regular basis, thankfully not so much successfully. But the consequences of these attacks are absolutely devastating, both financially and operationally. When a healthcare system loses its electronic health record, it instantly becomes far less effective, far less safe, because so many of the safeguards in healthcare are now built into the electronic health record. And the reality is that most people working in healthcare don't work on paper, never worked on paper, don't know how to write orders, don't know how to take them off, don't know how to do results reporting from the lab, from the X-ray, CT, et cetera, on paper. And therefore, we really are inexperienced in how to deliver healthcare without computers. Lastly, and I promise that this entire talk is not just listing all the negative things that are out there. I will try and offer some positive solutions in a moment. But you know, I think we have to think about the consequences of utility instability on our population, of course. We talked already about healthcare and loss of power. You know, many of you may have seen that there were several hospitals in California just this summer that actually had complete loss of power and failure of generator power due to brownouts. And the electrical grid really is not keeping up with the increasing electrical demands that we are seeing. The hotter it gets, the more air conditioning we use, the more demand we have. You can see that that's a vicious cycle. And thinking about that, what that means for community health overall, and then very specifically for the people in your communities that rely on powered medical equipment, ventilators, monitors, nebulizers, all of it is really, really important. And I expect most of you are aware of the MPOWER program, which is the HHS program that tracks Medicare recipients, and Medicaid recipients receipt of durable medical equipment. So you can look at who's been reimbursed for durable medical equipment at home that is electrically dependent, and you can map that to your community. If you're not familiar with the MPOWER program, I would strongly suggest that you become familiar with it, and you can work within your cities and towns, as well as with Mass DPH, to try and map out, in the event of a power loss, who is likely to be vulnerable. So, you know, unfortunately, continuing the sort of cavalcade of bad news before we turn the corner and start thinking more positively about this, I think it is also just worth talking about not just how the threats are increasing and how the threats are changing, but just how the environment is harder for all of us. You are all incredibly well aware, this is obvious to everyone, that the population is aging, and that the population, an older population, has more comorbid illness. So again, this is not news to anybody that the population is aging. It's also not news that older people have higher rates of hypertension, diabetes, kidney disease, all of it. But I think, you know, one of the less appreciated consequences of this, plus frankly just the consequences of COVID, is that the healthcare system is at unprecedented levels of overload. Hospitals are more crowded than they ever have been historically. Hospital occupancy is at record-setting rates. Emergency department crowding and volumes are at record-setting rates. And for a lot of different reasons, hospital throughput is exceptionally poor right now. The length of stay of time patients are admitted to the hospital is increased 8.8% across the country, and it's actually a little bit worse here in the Northeast. A lot of this has to do with access to subacute care. So a lot of hospital outflow relies on the ability to discharge patients to skilled nursing facilities and nursing homes. Flow from the acute care hospital world to the subacute world is much worse than it has been. You know how much the nursing homes and subacute facilities have struggled through COVID. That causes a backlog. And effectively, if you have less throughput through your hospitals, you have fewer hospital beds. It costs you beds and therefore it costs you capacity. And so the healthcare system itself is just under extraordinary strain. And you're seeing this, you're seeing the consequences of this in several different ways. This started before the pandemic, but it's really been accelerating during and as we're on this in this phase of the pandemic right now, is that hospitals are increasingly trying to deliver care outside of their walls. The most expensive healthcare resource we have is an inpatient hospital bed. And so hospitals are trying to deliver more care in the community through telemedicine. You're all very well aware of the revolution in telemedicine that happened during the early phase of the pandemic. There are lots of aspects of it that are really good and allow both patients to be much happier, being able to be home, receive care from their doctors. Doctors like it. I think we'll speak several times about health equity, and I think we have to really continue to work to make sure that there is not health inequity in how we're delivering telemedicine. But it means that a lot of people are getting care at home that they would have otherwise received in their doctor's office. Visiting nurse services, we've been using them a lot. They're not new, but they're expanding. What is new, and I think is an important trend for you all to be aware of, is increasing use of home hospital services. And my own system is investing heavily in this and expanding it. What this means is that there are certain kinds of patients that we would normally admit to the hospital. I'm an emergency physician. I see someone in the emergency department. I want to admit them because I think they need intravenous antibiotics or they need closer monitoring. I don't think it's safe for them to go home. Well, for a certain subgroup of patients who have relatively less acute illness, we often now are developing systems to send them home, and with an IV, possibly with a pump. And what we do is we have physician assistants or nurse practitioners, as well as nurses, visit them multiple times per day in their home. And a lot of hospital patients are only seen once or twice by the doctor in their room. They only are seen 2, 3, 4 times a day by the nurse. Those are the kinds of patients that are relatively lower intensity medical care that are moving more and more into the home environment. And this is coupled with more technology. So remote vital sign monitoring, the ability to constantly keep tabs on the patient so that if there's any change in their condition, of course, they can be brought to the hospital and brought into the inpatient environment. But what this means is that there are more people in the community maybe than you realize. And this is just starting. I don't think the numbers are big yet, but in the coming years, 1, 2, 3 years, this population is going to grow substantially. There are people in your community that are not who you already knew about. MHOA patients, the one I mentioned before, are patients with chronic medical conditions. So that they need home dialysis machine. They're on a home ventilator because that's chronically what they're on. This is more episodic care where it's hard to identify these people pre-storm, but there are people in the community who are getting ongoing IV antibiotics who need a home nurse, a home physician assistant or doctor to see them in their house. And they're only transiently needed those medical services. So if there's a coming hurricane, there's a coming major blizzard, it's going to be really important to think of new ways that you can identify and support those patients. Clearly, the healthcare system has primary responsibility to do that. But I think that partnership between healthcare and public health, and knowing who in your community might be especially vulnerable when there's a utility outage, if we have a sudden brownout or blackout, when there's a sudden disruption of the roadways, if parts of the community become inaccessible or others, there's new vulnerability at home that maybe we haven't appreciated, or we really just haven't had this population before. Increasing mental health needs, again, the trends were already worsening before the pandemic, but many things have accelerated, including some substance use disorder prevalence and issues, as well as, of course, depression, anxiety, suicidal ideation, et cetera. And it's obvious that the mental health system does not have the capacity to adequately respond to the needs that we are seeing. And we are all struggling to find new ways to support our community's mental health, especially in the absence of adequate available mental health resources right now, and funding that is also similarly inadequate. And you know, to sort of talk about the elephant in the room, you know, we all know how hard it is for the workforce. You know, public health staffing was decreasing before the pandemic. It was down 16% in the 5 years prior to the pandemic, and it's decreased further. We know that the pipeline of folks entering public health is not as robust at all as it needs to be. And you all, I expect, maybe every person in the rooms, probably at least most of you, are really, really, really tired. And you've been through a lot. You've gone through extraordinary pressure in every way, from your communities, from the needs, from just the amount of work, from the length of time you've been responding. And the same is, of course, true in the healthcare workforce. I will tell you, you know, as again, a healthcare practitioner, that the healthcare side of things is struggling with staffing more than it ever has. Right now, you know, you can see that there are 45% more job postings for nurses, 40% more postings for non-clinical staff. One of the biggest challenges in healthcare by far is just getting appropriate people to work in the jobs that are posted right now. Because of that, of course, the cost of healthcare is going up because the reimbursement is going up. It's really hard to do what we need to do when we don't have enough bodies, we don't have an adequate public health workforce, we don't have an adequate healthcare workforce. So, you know, that's all the negative, and you know, I really don't want to start off this wonderful conference that you're all having with so much negative, but I think we have to acknowledge what we're facing and what those threats are and what we need to be addressing as a public health and as a healthcare community together for Massachusetts. The good news is I think there's a lot we can do, and you know, while acknowledging the fact that we're all tired and we've been working really hard for a long time, it sometimes is motivational to think, okay, I can make a difference. There really are things that can be improved, and there's some strategies people are working on. And so, you know, to try and pivot more to the positive, to the future, I think there's a lot that we can do together as a community. And I will say this, you know, I kind of wish I was in the room to be able to see everybody for this, but you know, we have to acknowledge the fact that Massachusetts is, and has always been blessed with an extraordinary public health community that you know, we have people who are so good at what they do, who are so passionate about what they do, and really take action in ways we clearly didn't see across the whole country in the pandemic. We have a community that can make change and is really committed to this. And I wish I was in the room with you to talk about this, but the good news is there's a lot we can do together. This is, I find an interesting graphic when we start talking about what public health is. You know, we have 351 cities and towns in Massachusetts. I recognize that you all represent a very wide range of communities of, you know, small towns, larger cities, and everything in between. And you know, as we would expect, with the variety of health departments that we have and the health infrastructure, we have a wide variety of capabilities. I always love graphs like this because it shows the resilience and the power of very small departments and very small communities. I think it doesn't surprise me that in health education and emergency preparedness, very small communities do well. And we sometimes joke that, you know, the health director might be married to the fire chief or to the town manager, and they know the police chief, you know, because they're the neighbor 3 doors down. There's an extraordinary amount of resilience in small communities, and I think there's a lot to be said for that. But I think to show that across most of the health departments that we see, and this is a national ranking, not just US, but very small communities have a lot that they can do, and especially in the emergency preparedness realm. Small and medium as well, and you know, it gets hard to educate, to do good health education with really large communities, you know, when you're in the you know, hundreds of thousands for your municipal population. But I like seeing the fact that emergency preparedness remains one of those things that we do well in public health across the board. It's not at all surprising that it's pretty hard to have lab capacity or health economics capacity in smaller health departments. But the fact that we can do health education, we can talk about communicable disease control and disease prevention in health departments, no matter what, just shows that I think this is attainable for all of us, no matter what community you represent, no matter where you come from. I think it is time for all of us to start revisiting how we look at risk. There again, I'm sure there are 10,000 things on your desk right now that are of urgent attention for the health of your community. And there's a lot besides emergency preparedness that's just, basic part of what health officers do. That being said, when you go back, and I hope you go back and look at your emergency plans with kind of a fresh look following the conference, I think we have to have rational ways to prioritize our limited time, our limited resources. And I don't think we always think about risk in as clear-eyed or as strategic a way as we need to. There are three elements of risk. There is the probability of an event happening. There's the consequence on our community if an event happens. And there's our existing readiness for how prepared we are right now. And it is a really, really, really helpful exercise to look at all the hazards you're facing from an emergency preparedness perspective. Look at the likelihood and estimate the likelihood, always best to do with real data when you can. So look at the National Oceanic Atmospheric Administration's data for all the severe weather. Try and get updated probabilities for flood from some of the climate groups out there like Woods Hole and others that are available, but get really good probability data. Try and look at that consequence. Again, look at updated flood maps, not necessarily just available FEMA flood maps for your community. And then be very, very critical in your assessment of your existing preparedness. What are you really good at? What can you do with your fire, police, and EMS partners? What can you do with your municipal government partners? And then when you consider those variables, that will help you compare these unequal threats or very different threats of emerging infectious diseases, of contaminated water, of heat stress, of flooding, et cetera, which are hard to prepare for otherwise. I think, secondly, it's really important to try and be as scientific about emergency preparedness as you are about all other health threats, right? You look at prevalence of smoking in your communities or obesity, or you look at environmental health data, always as a scientist, right? You look at it to know what's the prevalence, what are the factors that are involved. Unfortunately, historically, we haven't really been as rigorous with emergency preparedness. There are a lot of myths about how disaster events happen, about how we work together, about what is most effective during disaster response. And these continue to propagate in the healthcare and the public health sphere, even in the emergency management sphere. And the problem is that we have these lessons learned articles, which I particularly hate after disaster events, because they rarely actually offer something new. It's just new to the person that wrote the article. And it's usually a restatement of something that was already described in the literature. The reason I put the photo on the right there is that clearly, of course, is an exercise of a mass casualty event. But we exercise in these very fictional conditions. Do we think really that a mother who has an injured infant is willing to lie in a nice little parallel row with the baby on her stomach until it's her next turn to get medical care? I don't think so. And I think we have to really look at what happens in events as they occur. What are the real community medical needs when there's a major flooding event? What are the real mental health needs after mass shootings? Become a consumer of after action reports and read the news about these events very critically, so that it helps inform your planning, because it really is the real world that should inform our planning, just like it is for every other health threat that we face. And I would argue that it's time to go back to the local public health emergency preparedness basics. This is my list, and so if people disagree with it, certainly please feel free to mention during the Q&A. But I think some of these are some of the most important things that local public health can and should be doing for emergency preparedness. I think clearly health officers are the best advocates for health concerns before, during, and after events. And sometimes it's not clear what to the fire or police or municipal leaders what the health consequences of an event are. And they're only thought of a little bit later. And so for you to be the people who speak up most loudly when there's an emergency incident in your town and say, let's think about this health consequence, or when you're planning for evacuation, that you advocate for those people who are dependent on powered medical equipment, or that you think about the health consequences when evacuating a section of the town. That's just extraordinarily important. And I think that should always be one of our principal goals in public health. You saw this in the graphic of capabilities, but I think public health still needs to have a very important role in outbreak recognition or incident recognition and investigation. And I know there's, partnership obviously with the state epidemiologist's office. And there's a lot that, can't be done just with the resources available in smaller communities. But still making sure that the public health is always at the table, that there's always that voice and that role is really important. And that sort of guides, I think, some of the next bullets, specifically risk communication. So many of you have been such extraordinary advocates for health during the COVID pandemic, with public health interventions, masking, distancing, gathering restrictions. We need to still be at the forefront of talking about risk. Unfortunately, it's no secret that our communities are more polarized than they ever have been. And I think that means we need to change our game. We need to find new ways to talk about risk that hit the whole population, including those that are not necessarily inclined to listen to us or agree with us. But if we're going to be good at our jobs, if we're going to be effective in managing disaster events, we have to improve how we work with our town managers, our mayors, our fire, police, EMS, emergency management colleagues. We have to be the voice of risk communication for health consequences, and we need to be good at it, and kind of constantly think about what's effective and what's not. Obviously, there's been so much discussion about mass vaccination or otherwise mass care that might be needed, mass prophylaxis in certain events. I still think that's a core function of local public health, and I think we need to look at our plans, look realistically about what the workforce assumptions are we have about this, right? That one of the hardest things about any mass vaccination effort is knowing where the clinical staff or the personnel are going to come from. Let's look at what we've learned through 2.5 years of COVID and look at what our capabilities are and be very realistic about what we can do, what we should do, and look at our plans for how we're going to do it. It's a cliche, you all know this, but public health emergencies don't care about municipal boundaries, and we need to really think continuously about how well we collaborate across jurisdictional lines, both again across city and town lines, across coalition and regional lines, and even across states. Many of you are in border regions in Massachusetts, and there are lots of parts of the state that are very tightly connected to New York, to Vermont, to Maine or New Hampshire, to Connecticut, or Rhode Island, and I'll say more about that in a second, but I think our ability to collaborate and cooperate is really important. We have an important role in population movement and evacuation, particularly for those who are vulnerable, and we have a really important role to advocate for medical needs sheltering. Obviously our sheltering plans are very different across the state. Many of you are very, very active in that. Others of you partner very closely with your town emergency manager or the Red Cross or others. But most of our plans for sheltering tend to run into trouble when we have people with chronic medical needs, people who are oxygen dependent, people who have significant health needs if they end up in a shelter. And I think we often fail those residents when we don't provide them the medical care that they need. From my perspective, the answer they have to go to the hospital is really not a tenable answer, especially in the healthcare environment we're facing right now. So just as one example of how I think we need to adapt and learn from lessons, the public is, I think, not as uniformly willing to adhere to our non-pharmaceutical intervention recommendations as they used to be. Right at the beginning of the pandemic, we did pretty well with gathering restrictions, with masking, with other restrictions that were out there. And the good news is that the data representing the effectiveness of non-pharmaceutical interventions. So how effective really was masking? How effective were these distancing recommendations? Well, they were very effective. And I think it's incumbent on all of us to know that literature so that we can have good conversations with those who may challenge us. But I think we also have to see what the dialogue is out there about those who are arguing that the economic consequences or the social consequences of restrictions are significant. I think we have to be very cognizant of real consequences. There's been a lot in the news this week about the real educational consequences of not having kids in schools. And that's really, really, really important data that we need to consider as we think about our own plans. We work with our school leaders in our communities to come up with the healthiest way to make sure that we're supporting our kids in our communities. And, I hate having this slide so late in this talk, but you can't talk about COVID without talking about health inequity. So much of what we saw in COVID had to do with existing health disparities and health inequity, but there was a lot of health inequity in the response as well. And this is not just related to COVID. It is very, very clear, I'm sure you all know it, that disasters disproportionately affect the most vulnerable always, right? Who can't evacuate? It's the people that don't have a car, that can't afford a hotel room, don't have anywhere to go. Who does the worst with shelter in place? The people that don't have a supply of food or water or medications. Who does the worst? Those who can't get risk communication from us or have language or media access issues. And I really think that we have to start reframing our emergency preparedness planning, starting with those who we know are going to suffer the most. It's very common, and I'll say I've done this, and my own system has done this. We start our emergency planning thinking about everyone. We think about the population as a whole, and then as we finish those plans, start thinking about who's vulnerable and what we need to tailor or add on. And I really think almost that planning process needs to be flipped on its head. That we start with those in our community who we know will suffer the greatest consequences. Who do we know is vulnerable from transportation, economic, linguistic, racial, ethnic vulnerability reasons in our communities, and how do we support them? How do our plans start with targeting those individuals and support them and give them what they need? And then what can we generalize to support our communities as a whole? Obviously, those with resources tend to do better in disaster situations, almost no matter what. And I mentioned coalition and regional planning, and I think there's been a lot of increasing awareness on the healthcare side that we need to do a much better job collaborating among hospitals. The truth of the matter in a mass casualty event is that most hospitals are not trauma centers. And we have not done enough planning on the trauma side to really figure out how, if patients end up in community hospitals, and there are lots of trauma patients in community hospitals, say after a mass shooting event, how they most effectively and efficiently get to trauma centers for the definitive care that they need. The epidemiology of disaster, the science of disaster is really clear. In most no-notice events, patients will go to the closest hospitals. And that doesn't mean a trauma center or a pediatric center or a burn center. And so patient redistribution is a huge issue and requires a ton of planning with the hospitals, with the EMS systems, others to make that work. I think we really have to look at it both on the healthcare side, but on the public health side. Where do we have strengths? Where do we have more bandwidth in our public health departments, in our public health community? And I know this is hard. There's, I will freely admit, not representing a local health department, there's a lot there are very real constraints from what you can do within your budget, within what your town manager or municipal leader wants you to do, serving your community versus collaborating with other communities. But the reality is, especially in a state like Massachusetts with local-based public health, we have to continue to collaborate and grow. There's so many great examples. I would venture to say that most all of you are actively collaborating with many other cities, towns, with the coalition that you're part of. So I'm not insinuating that there isn't already great collaboration. There really is. But I think we have to double down. I think we have to do more. The health and medical coordinating coalitions, there's 6 of them in Massachusetts, really make sure that your city and town, your health department is engaged in that coalition work. The coalitions work with the state health department, and one of the bigger initiatives recently that the federal government has started is called a Regional Disaster Health Response System, RDHRS. That RDHRS program for all of New England is actually based at Mass General. It's my program. And we remain eager to work with you and with your healthcare entities to improve disaster resilience so that the healthcare system does a better job of planning. So I just want to end talking about what I think the priorities are for all of us working on public health emergency preparedness. And then if there's time at the end, see if there are any questions. But I think, I put it a little deep into the lecture and I feel sheepish about that, but I think it's really the top priority is that we put vulnerable populations, those who suffer chronic health inequity, health inequality, and challenges with access to care are the center of our planning and response. I think as we dust off our emergency plans, trying to, come out of 2.5 years of response to the pandemic and look at all the other planning priorities we have to really start with that population. I think we need to commit to using data and science in preparedness the same way we do in the rest of the public health work that we do. I think we have to acknowledge how the landscape is different. This is more kind of a hospital problem, not so much a public health problem, but I hate to say this to you, but hospitals are much less ready for a mass casualty incident than they ever have been. My emergency department is more crowded with more people in the hallway than we've ever had in history. And if God forbid there's another Boston Marathon bombing, there's another mass casualty event, I will absolutely struggle right now to find enough rooms to resuscitate those patients to give them the care that they need. It's a consequence of what happens when the healthcare system is so overloaded. I think that analogy or that example describes how we're struggling with all sorts of different challenges in public health emergency preparedness, but I can't ignore the reality of how crowded the healthcare system is. And I in my own world, I'm going back and really looking at how I can improve my plans to fit the reality I face. I think we all have to do that. We need to collaborate. I just was talking about that. And I think all of us need to loudly use our voices to advocate for increased funding, increased attention to public health emergency preparedness, to healthcare emergency preparedness. There has been some funding for the public health workforce. There's been some funding for the CDC. But I would say probably all of us are reasonably disappointed that at the federal level, there really isn't that commitment to really learn the lessons we should have been learning over the last 2.5 years, that commitment to fixing the problems that have been decades in the making with underfunding of public health. It's not there. And I think we need to be collectively as loud as we can be in saying it's not there. We still need this. We've lost 1 million lives across the United States, a lot of which were preventable losses. We need to develop a better system. I think one of the strongest ways we do that is actually developing better metrics and measures. I think the more we can describe the deficiencies, the more we can describe how we make progress, the better we'll do with Congress, the better we'll do with the American people, to have people listen to what we're arguing. So that is what I had to say. I hope this was not horribly negative for the 9 a.m. start to your meeting. But really, it's a great pleasure to be able to join you. Thank you so much for the invitation. And again, if there are questions, I'd be happy to answer. And just to be clear, I can only hear anything if it's on the microphone. So
we do have microphones here. If you have a question for Dr. Biddinger, just raise your hand. Ray and I will come to you.
Yes.
I got it right.
Got it. Thank you. Hold on, Paul. We do have a question.
sounds good.
Hi,
Hello.
I'm wondering what your favorite risk analysis tool is. I've seen so many different iterations. Do you have one that you like the best?
So the answer is sort of yes and no. I actually don't think any of them is adequate. The Kaiser Permanente one that's used for healthcare, I think, can be adapted for public health. The problem is that what it tries to do is put numbers to those elements of risk that I mentioned, and it gives you basically a 1, 2, 3 score for low, medium, and high. And the beauty of the tool is that it does do the calculation for you. The numbers themselves are meaningless, right? You'll end up with a risk score of, say, 2.2 for earthquake. And that doesn't really have a meaning, but it's all relative. So if 2.2 is earthquake, but 2.9 is pandemic or emerging infectious disease outbreak, it's the relative ranking that is the most helpful. So I would say it's freely available on the web. You can also get it from the California Hospital Association, but the Kaiser Permanente one is good. And the reasons that I like it are it breaks the risk categories down into the 3 elements individually. It does the math for you in doing the calculation. And I think it's a pretty comprehensive list of health emergency threats, not just healthcare, but you can add to it as well if you want.
Last one.
Can you hear me?
Last question.
So another question. You mentioned that healthcare is moving from hospitals in certain situations into the home. Can you comment on the percentage of people using those services now versus predictions for the next 10, 20, 30 years?
Sure. I can at least give you my own hospital's example, my own system's example. So again, I work for the whole Mass General Brigham system. And now for our whole system, it's probably about 20 patients. So a really, really small number. But we're planning on ramping up to 250 patients or so by 2 years. So if that's one healthcare system within Massachusetts, I do think in the next couple of years, it will be in the hundreds, and within 5 years could potentially be, getting towards 4 digits.
Paul, thank you so much. We so appreciate you being here virtually. Thank
It's
you
my-
very much for
my
your
pleasure.
time.
Thank you all. I hope you have a great conference.
And that's quite the applause. Thank you very, very much. Have a great afternoon. We do hope you feel better. Thank you, everyone. We're going to divide up the rooms, and so food track can start for 10 o'clock.